Joint Health Scrutiny Subcommittee, Improving Healthcare Together 2020 to 2030. I have temporarily taken chairing of this meeting while Colin is trying to rejoin. Colin Steers tries to rejoin the meeting via this Google link. But in light of the fact that he hasn't joined, I'm just going to check with the rest of the committee whether they are in agreement for me to start the meeting formally.
Yep, agreed.
Agreed.
Okay.
Agreed.
So the meeting's formally started. Obviously, we've got a number of people here this evening. I don't know whether it was... so maybe this is an opportunity for people to just formally introduce themselves. What I'll try and do is I'll go over to Kathy and ask her to do introductions for the people present.
Thank you. Okay, so thank you, Acting Chair. If members, as I read your name, could you turn on your mic, if you can, and your camera, and state that you're present, and if you have any declarations of interest. After you've spoken, if you could turn off your mic and your camera. So, Councillor Bill Chapman. We can see your hair, but we can see your hair. Councillor Sean Fitzsimons. I'll come back to Councillor Peter McCabe.
I'm here, but I've joined by phone because my computer saying the meeting doesn't work on my browser.
Okay. And do you have any declarations?
No.
No. Thank you. Councillor Anita Shaper.
Yes, here and present. Thank you, Councillor for Kingston Council.
And do you have any declarations?
I do not know.
Councillor Colin Steers, we know. We've also got several from the Improving Healthcare Together programme and other experts. If I just read out the names of the other people that we have in attendance of the meeting who will come in to provide presentations or take questions at some point during the agenda. So we have Andrew Demetriatis from the IHT programme, Charlotte Keeble from the IHT programme, Iona Mirren IHT programme, Dr Matthew Tate, Surrey Heartland CCG, Sarah Blow, South West London CCG, Andrew Murray, South West London CCG, Daniel Elkeles, Epsom and St Helier Hospitals NHS Trust, James Marsh, Epsom and St Helier NHS Trust, Dr Hills, Charlie Wilson Opinion Research Services, Kester Holmes Opinion Research Services, Brian Niven, Mock MacDonald, Jerry Latter, YouGov, Kate Duxbury, IPOS Mori, Roger Steer, External Independent Advisor, and David Olney, Scrutiny Officer for Sutton Council. Thank you, Chair. If I could ask you to start going through the agenda items as laid out in the agenda, please. The mic.
Thank you. For the record, I also just want to add my declaration of interest. As a councillor for Croydon, I want to declare that I have no other interests in regards to this matter. So I'm going to then propose that we go on to item 4, which is the minutes of the previous meeting, and to approve as a correct record the minutes of the meeting held on the 26th of September 2020.
Approved.
Are there any issues, or can Colin sign them as a true and correct record? I'm not hearing any dissent, so the committee has approved those minutes of the previous meeting. Item 5, which is Improving Healthcare Together Joint Health Scrutiny Committee status report and moving forward. I understand we have a summary report to be set out. Can the relevant officer be able to just give us a brief outline of the item?
So this will be presented by David Olney, Sutton Scrutiny Officer.
Over to you, David.
Thank you, Councillor Fitzsimons. Thank you, Acting Chair. Good evening, everyone. Yeah, this is a brief report which is in essence summarising the position of the Improving Healthcare Together Joint Health Scrutiny Committee over its existence in its first phase as a discretionary committee, and then subsequently with the launch of the formal public consultation as it's moved into its mandatory phase. The report usefully places in one place, in one location on the record, all of the preparatory work that the standing South West London and Surrey County Council Joint Scrutiny Committee did in establishing the subcommittee and providing the boundaries of responsibility for the Improving Healthcare Together subcommittee. There are three issues which need to be addressed as we go forward into the next phase of work. The first of which is for the committee members, the authorities that are party to the IHT subcommittee, to confirm that their authorities are sufficiently impacted by the proposals that they wish to be party to the subcommittee. The second is that those authorities that have not done so already take this opportunity to indicate that they will go away and discuss with their relevant council authorities the position that they wish to take with regard to their potential use of the power of referral to the Secretary of State if they have any, if they are discontent with the proposals after the consultation has concluded. And thirdly is to give a broad indication of the future work that the committee may be engaged in as NHS colleagues move to their decision-making phase.
David, thank you very much. Bill, it's Councillor Collins here. I've managed to get over the vagaries of IT. Can everyone hear me?
Well done. Yes, I have too. Yeah, so I've done it by coming in on phone.
Okay, colleagues, can I take over for chairing the meeting now? I apologise for
yeah, certainly. Yep.
Okay.
Go ahead, Colin. The only issues was the declaration of interest for you guys who haven't yet done them.
I have no declarations of interest regarding this meeting tonight.
Neither do I.
Okay, thank you very much. Anyway, I apologise to everyone that I wasn't in at the start of the meeting. I think you'll all realise that this is an interesting way of doing things. So, colleagues, before you on item 5, we just need to confirm what David Olney has said regarding the papers in item 5, and also looking at the future work as well. We need to, as colleagues will realise, that we are to present our report by the 19th of June to colleagues at the NHS and the South West London Scrutiny Committee. So there that be item 5 on the agenda. Could we confirm that, please? Items 2.1, 2.2 and 0.3.
Yeah, confirmed.
I can confirm also.
Yep.
Okay.
I can confirm also.
Thank you very much. Thank you. David, so we've now completed item 5. That's the decision making. Item 6, please, if we could move on to Improving Healthcare Together and the programme update, opinion research services.
So can I just introduce Kester Haynes and Charlie Wilson? There's Andrew Dimitriades speaking to the programme. Good evening, Colin. So what Charlie and Kester are going to do is give a summary of the consultation findings and then leave that open to members of the committee for any clarifications or questions. So I will hand over.
Thank you very much, Andrew. Thank you very much, Chair. It's Charlie Wilson here from Opinion Research Services. I hope that you're able, those of you joining on computers now, to be able to see a presentation on your screen. Could one or two people maybe confirm that for me?
Yes, confirmed.
Yeah.
That's great. Thank you very much. So I'm going to give a very brief overview of some of the key findings from consultation feedback. I'd like to reiterate that this is not to be viewed in isolation. It's very much a taster of the full report and just summarises some of the key findings. I'm going to try and cover it as briefly as possible, as I know there may be questions. Just useful to ask the question, what is public consultation? And consultation has been described as a dialogue. What it is not is a vote or a referendum, but it is an opportunity for an exchange of views, which should be conscientiously taken into account by decision makers. And this consultation process has been independently quality assured and found to meet best practice requirements by the Consultation Institute. Some of the key milestones. So pre-consultation began in 2018 with formal consultation taking place over the early part of this year. And there was a good level of engagement across a wide range of consultation strands. In terms of key findings, many of the consultees recognise that the challenges identified in the IHT proposals are there that face the NHS nationally and locally. And the proposed model of care put forward by IHT gained broad support across different respondent types and across the geography of the Epsom and St Helier Trust catchment area. However, those levels of support did vary by geography, with more individuals, particularly in the wider Merton CCG area, viewing the proposed model of care as poor or very poor. When we look at opinions on the model of care and break that down by consultation respondent type, then what we see in the consultation questionnaire results is that the vast majority of the over 700 NHS staff members who took part is that the proposed model of care is a good or very good solution. When we look at those non-NHS staff members who responded to the questionnaire, over 3,300 of them, and at the residents' telephone survey results undertaken by colleagues at Ipsos Mori, then we see that there is also an overall majority viewing the model of care as a good or very good solution. However, when we break down those results by area of residence and start to look at geographical variation, as I mentioned, then while support for the model of care remains strong among NHS staff members who are also local residents, regardless of where they live, among the other individual respondents taking part in the questionnaire, the majority living closest to the Epsom hospital site and the Sutton hospital site by time of travel were in favour of the model of care, with a majority in favour, while views of those living nearest to St Helier Hospital much more evenly split. When we look at the same questionnaire responses and break it down by CCG areas, then we see there that residents living in Surrey Downs and Sutton CCG areas are positive in regard to the model of care, whereas there we see, as I highlighted before, that among questionnaire respondents who live in the Merton CCG area, and then a majority view the model of care as a poor or very poor solution. With regards to the question of a location for a new SECH if one were to be built, and this is a question that was addressed in the consultation questionnaire and the resident survey by asking people their views on each of the sites individually. There was no attempt to gain any kind of ranking through these questions. What we did see is that across all of the consultation strands, then on balance, Sutton did receive more support than either of the other two sites. But again, very strong variation depending on the geography where respondents lived. Support for Sutton as a site was greater among those who supported the proposed model of care. Support for Epsom or St Helier as a site tended to be mainly from respondents living closer to those hospitals, and we'll look at that in a little bit more detail shortly. Again, looking at the different consultation strands and the different respondent types, then what we see is that the majority of NHS staff in particular feel Sutton would be a good SECH location, as did professional and clinical groups who responded. But there was also local support for other hospitals, with political organisations and elected representatives tending to voice support for their members or their constituents' closest existing hospital. When we look at questionnaire respondents in particular and the residents through the survey, then these two sets of graphs. On the left-hand side, we have views on the sites, looking specifically at those who viewed each of the sites as poor or very poor solutions. And what we see there is that Epsom and St Heliers sites did see more individuals and NHS staff members responding by the questionnaire viewing those negatively than those who viewed them positively on the right-hand side. Whereas, again, for Sutton as a site, what we see is that that is the only site among non-NHS staff responding to the questionnaire which received a positive balance of opinion. Views among residents through the survey, we saw there that each of the three sites on balance was viewed as potentially a good or very good solution. Now, from other consultation strands, then petition signatories, some of the written submissions from members of the public, we saw a strong opposition to the model of care in its entirety, to any centralisation of care and any specialist emergency hospital. That opposition was also seen at the larger public meetings that took place, with demands for all services to remain local. In the smaller public meetings, and very particularly in the targeted workshops and focus groups undertaken by YouGov, then participants typically viewed the location of Sutton for an SECH as a good option, although again there was localised support for one or other of the existing hospital sites. Again, important to look at the geography and the variation there, and basically what we see is that again, strong support for Epsom as a site for an SECH from those living nearest to Epsom, strong support for St Heliers as a site for those living closest to St Heliers, stronger support for Sutton as a site from those living closest to Sutton, but also a sizable proportion, albeit not a majority, of residents living nearest to Epsom or to St Heliers who took part in the consultation questionnaire, viewing Sutton as a good or very good solution. And this graph again just indicates where people did offer a clear preference, viewing only one site as a good or very good solution. Again, we just see that pattern, localised support for two of the hospitals and also for Sutton Hospital, but those dark yellow dots more widespread for Sutton. So that overall narrative there. And then briefly, this last slide, very importantly, and actually the vast majority of the consultation feedback report covers the wider views, concerns raised by respondents across all of the consultation strands. And what we see is that travel and access is the primary concern in relation to the model of care and to any location in SECH. And that concern around travel and access really is seen across all of the other concerns that are raised. So, for example, when we look at concerns around maternity, then again it's travel and transport and the amount of time it might take for people to get to a new SECH, to those maternity services, that is of concern. However, with maternity as an example, there are also other concerns, specifically around the separation of prenatal and antenatal care and the way that maternity care staff would be distributed between the hospitals and any impact that might have on the consistency of care for expectant mothers. Health inequalities was a very strong theme coming forward from a number of consultation strands, with concern particularly expressed around impacts for people living in socio-economically deprived areas, although also residents who are older. There was concern about impacts on those groups as well. But again, those concerns really focused on issues related to travel and access and to journey times. There were a number of submissions which, particularly the written submissions, which put forward alternative suggestions and also contrary evidence or alternative strands of evidence during the consultation. Some of those very, very detailed, and they are not only summarised in our report, but have also been published in full and been made available publicly. And then some other themes that were arising throughout as well, concerns around the impact of the proposed changes on other providers and local hospitals outside of the trust area, potential impacts of three-site working, if there were to be a new SECH in a third location, including staffing and transfers between hospitals, consternation regarding bed numbers and the modelling of bed numbers as part of the preparation of the proposals, and also concerns around possible future privatisation or closure of existing hospitals. So, Chair, I will hand back to you. That was a very brief summary, but I hope it's been useful.
Thank you, colleagues. Thank you very much. Colleagues, do you have any questions that you would like to ask Charles on this one?
Yes, I
Colin.
Chair.
Say again, who's... Hello?
Colin, can I just make a comment?
Is that Bill? Yes, Bill, come in.
Yeah, thanks very much. Yes, so the concerns that people have expressed there very much echoed in amongst our members of the HOSC, and you know, in particular, I'm just going to turn this off. In particular, oh, it won't go on. Concerns about the that's better. About deprivation, and I think more broadly, there's a concern about amongst some members that there won't be enough funding available to support the required infrastructure, both infrastructure to provide public transport and roads and the rest of the network. And yeah, both in terms of the changes to the hospital, but also hospital provision, but also in terms of the overall growth of population, which is equal. And in fact, one of the challenges that we have is that some of our members feel that the requirement for infrastructure is not clearly enough stated or evidence, so that there are a lack of data there. But I can raise that point again later. I think other than that, lots of the points you made there were echoed from our people. You know, pretty well all of them have come up in our discussions. So that's reassuring, you know, that you're picking up the same sort of messages that our members do from their constituents.
Thank you, Bill. Could I ask Councillor Shaper?
Thank you, Chair. Yes, thank you, Charlie, for that, for those slides. What I just wanted to say was I'm interested in the essence of the consultation where the feedback called for alternatives and variations to be explored, because I think you captured an awful lot of feedback, and I think that there was a theme running through about travel and access as being both for those people that you know, around the Sutton area who actually were more inclined to favour the model of care, and also the interesting point about those people that supported the model of care, that they were in favour of the Sutton site because they also were in favour of the model of care. So I thought that was a really important finding, or that was captured from the feedback. So I think my question was, did you find during the consultation that there was feedback that captured the difference in people's minds when they talked about travel and access? Did you find that the feedback captured feedback from those respondents across all the different types of ways they could reply about the distinction between methods of transport via blue lighting and car, or going as visitors? Because I think it would be really interesting to know the type of respondents and whether they gave you an indication of whether they were current patients or whether they had experiences of being a visitor. And I was just interested to know whether you feel that essence of the feedback has been captured from those participants.
Charles, if you could answer those two questions, and then if any other colleague wants to ask any more.
Yeah, thank you, Chair. Thank you, Councillor, for that question. Yes, so certainly the evidence that we see across all of the consultation strands is that there really is a vast range of different types of respondents, many of whom are patients or have family members who have been patients, and are very much speaking from personal experience. So many of the comments that we get coming in are very much, this is how I feel based on my personal experience, and that's really important for us to see. What we see is that those concerns around travel and access cover both blue light admissions and private transport. They relate both to patients getting to emergency care when they need it, and to visitors who would then subsequently want to see their relatives. And what we see, and I think this is a very important point, if I may just raise it, is that those concerns about travel and access are shared by people who both support and object to both the model of care and to the different locations. They're shared. For some, they are things that need to be mitigated, and they want to know what will be done to deal with that. For others, they are a reason to object and oppose specific sites or the model of care in its entirety. Also, those concerns around travel and access, very similar concerns raised about all three of the sites. So while Sutton as a site is the sort of the new option, the unknown to some extent, people did raise concerns that with a new facility being built at one or other of the existing hospital sites, that an increase in traffic, an increase in the number of visitors, an increase in ambulance journeys to that site might also have an impact. And again, that was being raised as something that might need to be mitigated again in the future. So
thank you, Charlie. Thank you, Charlie. I do agree with that, actually, and it is a really important point to raise about the fact that you have a option, three options. Say you're just, the feedback is suggesting that whichever option is chosen, there's always going to be a certain percentage that will be in favour or not, depending on where that location is. Thank you.
Could I ask if any other councillors would like to ask Charlie a comment or comment on this, or question on this report?
Yes, please, Colin.
Yeah, please come in, Peter. You're on the phone.
Yeah, it's Councillor Peter McCabe from Merton. I attended one of the pre-consultation meetings in my own ward in Merton, and it's the ward that's closest to St Helier Hospital. And one of the strong views expressed by local residents was that this was the umpteenth time that they had seen attempts to remove A&E and maternity services from St Helier Hospital, and they didn't believe it was a genuine consultation because it was all, the decision had already been taken. And when I hear you saying that you're kind of dismissive of those people and their views because they live near the hospital, and yet you don't appear to dismiss the views of staff from the hospital. What is it that encourages you to give greater weighting to the views of staff than the views of local people? Those local people pay their taxes and they expect local services, and yet you just appear to dismiss their views, and you almost suggest that perhaps you should have a consultation that consists of staff and people living a long way from the hospital. Perhaps we should consult with people from Yorkshire.
Yes, so Chair, I'm very happy to respond to those
Carry
points.
on, yeah, please.
Yeah, so certainly what we do see across many health consultations is that NHS staff are particularly supportive of proposals, and that is actually the very reason that we separate them out. If we just included all respondents to, for example, a questionnaire together, NHS staff who are local residents and in with other residents, then what we see is everything is skewed positively. So while I understand that the way results get presented is always clunky, we actually take a very deliberate effort to separate out those very positive views from the much more varied and nuanced views of non-NHS staff members. And throughout the report, we've spent a significant amount of time covering the strength of and the details of local views about their local hospitals. So I certainly hope that the report doesn't give some sort of impression that we've attempted to weight one or other view more importantly than the others. And returning to that sort of early point that I made, the point of consultation is not to try and get a single answer to a question. It is to convey that rich variety of views from across the different geographies, from across the different respondent types, across the different consultation strands, and ensure that all of that evidence is presented in the report, and that's the effort that we've made.
If I can come back on that, Colin, I mean,
yes, certainly.
I'm reading in paragraph 146 that 59% of residents seeing St Helier as a good or very good solution, and I'm looking at paragraph 4.2.1, just under 3/5, 58% think St Helier Hospital will be very or fairly easy for them to travel to, and in 4.2.2, residents from BAME background and the most deprived areas are more likely to say it will be easy to travel to St Helier. And I think, given what has emerged in recent times about health inequalities, where we've heard that the poorest people have actually seen a reduction in their life expectancy, and given the information that's emerging about COVID-19, then I would have thought that those views from those groups would be given proper consideration by the NHS before making decisions. And it does seem to me that when you look at the areas of deprivation, most of them are around the St Helier site, and those people have greater need of their local health services.
Charles, I'm happy for you to comment on that.
Well, I think very good points raised there with regards to the importance of looking at issues like health inequalities. But of course, from our role as an independent organisation reporting on consultation feedback, then we've simply prepared a report that includes all of those views, including the very detailed, very thorough submissions coming through from Merton Council and from other respondents with regard specifically to health inequalities. And of course, it now goes to the decision-making board to take all of that into account as they move forward.
Councillor Fitzsimmons.
Thank you, Colin. Having read the report and listened to and looked at the presentation that was this evening, I mean, obviously, as a committee, we're in a difficult position because we have a number of representatives of the various areas that will be directly affected, and some of us are indirectly affected. The concern I have, as I like to think of myself, maybe is, and it's no comment on anyone else, but you know, we are acting in an independent manner, is that the case for a new hospital is self-evident. You know, both hospitals have their issues, and there's been a need for a new hospital for many a year, and many a government has promised it, and so far none have delivered one, and we carry on with substandard facilities. The question is, and the reading of the report of the consultation side is, residents would prefer to have healthcare that is close to their home, and a judgment then has to be made about within the finances allowed, where's the best place for it. But I do think Peter makes a point about health inequalities and the need to have a greater regard, particularly in this time of COVID-19, when that in terms of infection throughout the community, certain parts of this area that's being reviewed have had much higher levels of COVID-19 deaths than other areas. The question that I think, I mean, I think the fundamental issue with this, or maybe a fundamental problem, is that we're trying to put together three different areas and trying to provide one hospital for it. And I know from my own experience in Croydon that having a hospital in West Croydon doesn't appeal to some people who live in the south of the borough. And that's, you know, I think that's a shame that people from some parts of Purley and Coulston seek hospitals outside London. And, you know, I do have a concern partly that whatever hospital is chosen, whether at Sutton, Epsom or St Helier, we are going to have a real issue about whether people will choose that hospital as their local choice. Because either because of transport issues or just because they don't see it as the hospital for them, and I will make no judgment on that. And this consultation seems to me to reinforce my concern that we're trying to put a jigsaw together that just won't fit, that it's just may not be possible ever to provide one hospital that meets the needs of the residents of Epsom, Sutton and Merton. So those are sort of the two main points. One, I am concerned about the health inequalities impact. And secondly is I'm to be convinced that one hospital for these three areas is the right option.
Charles, if I could come in and ask a question here. It's Councillor Colin Steers from Sutton. Just a bit of clarification, really. I know my colleague was mentioning that the choice of where to go to, but in these proposals, there is very little overlap in service delivery of the new site with the district general hospitals that will remain. So do you think that people in your consultation understood that what services were going to be delivered on that site, or they were just looking at the question of moving bricks and mortar around? And I just wondered what the feeling you got about that.
Good question.
Yeah, thank you very much for that question, and it's an extremely good one. And the reality is that in consultation like this, particularly when you have so many different types of consultation feedback, is that we don't always know exactly how people are responding or what they're responding to. Now, one of the reasons that we tend to focus quite strongly in some respects on formal consultation feedback via questionnaires, surveys, focus groups, and also written submissions is we begin to see much more of that detail there in terms of people's views. And we certainly did see that there are a lot of people very positively engaging with the question of an entirely new model of care for the area, with the centralisation of those 6 core services and a change to a more district model with 85% of services remaining in existing buildings. Now, how they responded to that obviously varied very much, and we cover that in the report. But we did see that there was a good level of understanding among many of the respondents of what was being proposed. We did see some evidence as well in other areas that perhaps people didn't have a full understanding, or perhaps were focused on one particular issue. So a lot of people talking about hospital closures, concerns that whole hospitals would be closed, which of course were not part of the proposals. But generally, we did see a good level of understanding there of the proposals themselves.
Thank you, Charles. Has anybody, any other?
Can I just come back in on
council
that?
colleagues? Yeah, certainly. Yeah, certainly.
Well, I think that was the point I was making. Because if you go to page 45 of one of the agenda packs and of your agenda item 6A, and it talks about the model of care, a new way of working. And I think Peter mentioned this about the fact that NHS employees talk about it being a very good 51% of NHS employees say it's a very good solution, and another 30% say it's a good solution. But when it comes to the 3,300 individual responses, 25% it says it's a very good solution, and 31%. And what we've just heard is someone saying, well, they don't understand the model. So in a sense, if only they understood the issue better, then we would get a different response. But I would then say that's a failure of consultation. Consultation is supposed to be an opportunity for the person who's consulting to explain to the person who's being consulted the complexity of the subject. And we were reassured on previous occasion that all effort would be made. But what we're hearing effectively is the reason we don't have overwhelming support for it is that people probably didn't understand the issue. Now, I think that gives me a cause for concern.
Could I just come back immediately on that point? That I certainly, I'm not suggesting that misunderstanding of the proposals is a factor in terms of views on the model of care or on the proposals as a whole. That was certainly not my intention. It is a fact that across the different strands, we see that there are differences in the level of understanding, and that some consultation strands, people have clearly availed themselves of the information that is available, whereas some consultation strands, we either can't tell if they have or not, or there are some suggestions in responses that they may not have, and rather that their views are based on other information that's out in the public sector, in the public sphere. But certainly not suggesting there's a direct correlation between the level of understanding of the model and views on the model in particular.
Sean, is that answer satisfy your concerns?
Of course, I would. Anytime an officer makes a statement, I would take them on their word. I'll just reinforce the point that Peter made, that one of the key things that we're having to look at is whether we think this model of care is the way forward, and from that flows a decision potentially down the line of which is the best place for this new model to be enacted, as with and with the refurbishment of the existing buildings as part of that. And I just wanted to make certain that we understood that there was significant concern from the formal consultation, which we understand from the officers tonight we should give weight to, rather than maybe some of the informal political party political representation. And my maths makes that 33% of the individual responses said it was a very poor solution or a poor solution, with a further 11% making no judgment between whether a poor or a good solution. I won't add any further comments.
Could I come in? I think one of the other topics that questions that need to be raised is the report says that 46% hadn't heard about IHT. That says to me, did you think that the consultation was wide enough? If you had 46% said they hadn't heard about it, isn't that slightly worrying? And did you go back and revisit that after some of the consultation?
I think perhaps it might be for a member of the IHT team to address that issue with regards to promotion of the consultation itself.
Now, I'm happy with that one, Charles. We've got Andrew coming on in a minute. And Anita, you'd like to say something?
Thank you, Chair.
Andrew, if we could let Anita say that, and we'll take that as part of your questions.
I'll go back on mute.
Thank you, Chair. Charlie, my interest, particularly in around the questionnaire, is the methodology and the assurance that you met that the steps were taken, necessary and appropriate steps were taken for it to be as representative as the population as possible, because clearly there were different strands to the consultation exercise, but also in terms of location, to make it as easy for people in different locations to be able to come together if they wanted to, particularly focus groups, and also telephone survey, etc. So my question really is about the observation that some strands of the consultation were giving different results. So clearly the results being slightly more positive amongst residents to the telephone survey on the proposed Sutton site, as opposed to other strands that would have yielded different results. So from your experience, what can you infer overall from the various strands that were used, whether they were how are they weighted in terms of the actual responses that you got? I'd be very interested to know how representative of the entire population they were, or whether some groups were more geared towards localized issues when you had the responses. Can you make any more inferences to that? I'd be really interested to know. Thank you. Thanks, Chair.
Yeah, well, thank you, Councillor. I'm happy to respond to that. The very quick answer, without going into a broad discussion of consultation methodology, is that basically there are certain strands which are designed to be representative of the population as a whole, and specifically that's the telephone survey conducted with residents and some of the focus groups conducted by YouGov. With the other consultation strands, they are open consultation. So with the questionnaire, for example, anybody who wants to can take part in that questionnaire. Anybody who wants to can supply a written submission. But of course, not everybody does. Many people may know about it, but choose not to respond. So again, it comes back to the question at the top, which is, while it's important to get a sort of a view of the balance of opinions, that the purpose of consultation is the dialogue itself and the findings from that dialogue. So the questions are things like, are there particular views, whether they're majority views or minority views, on the proposed model of care on each of the 3 sites that need to be taken into account, that bring forward new, particularly cogent arguments in relation to those proposals. And so the purpose of the feedback report is to bring all of that response whether it's from a single individual, something of particular impact, or whether it's a more representative view from a particular consultation strand, like the survey, which is designed specifically in that way. So a brief answer to a complex question and a very good question. But
well, I think just very briefly, Chair, if you don't mind, there was just one last thing. It was just about the idea that if you had, say, a majority in favour of one particular sort of response gearing to, say, the issue of location rather than model of care, how would you then be able to say that that was that a localised in a particular area response, or how would you then equate that to being representative of the whole population? Because the point is that if you had, as you say, an argument for one particular site over another, then that would be your answer to, well, a certain group of individuals in an area have all answered in the same way. Therefore, there's going to be other areas of the population that would not agree. So that's what I'm trying to get at, is that there is always going to be a proportion of people who, from the results clearly, who aren't going to be happy because certain individuals from one area want the location near them.
Yes, and that is the case. There are a lot of people who would say that they want if there is going to be a new hospital, they want it closest to where they live. And that's a strong theme. I think, again, it's very difficult to try and identify a view that is representative of the whole area. And we have to really look at locations and particular groups in order to gain a good and detailed understanding. But what I would say is that when we look at the resident survey undertaken by Ipsos Mori, which is a representative view, it's possible to look at that as representing people across the whole area. Then what we see is effectively that there is support for all three of the sites. Very simply, there are more people in favour of each site than there are against each of the sites.
Thank you, Charles. If we
Colin,
could move on,
may I speak, please?
Who's that coming in?
It's Bill Chapman.
Bill, last time, and then we'll move on to 6.2.
Yeah, okay, yeah. It's just to say that I have a lot of sympathy with what Anita was saying about the possibility of small groups unduly influencing this sort of consultation by getting together and organising themselves. So I think it is very important that the type of consultation is broad. For instance, you mentioned focus groups and telephone contacts as being important in that they guard against that sort of behaviour. And I'm very reassured to hear that there was a lot of that, those two types of interaction carried out, and that, I think that speaks well of how the consultation took place. That's all I have to say. Thanks.
Thank you. If we could move on now to item 6.2, and I'm sure Andrew Dimitriadis from the IHT programme would like to comment on some of the questions that we've had previously. So, Andrew, if you'd like to pick up the question we had previously, and then if colleagues want to come in with further questions.
So I'm not going to run over the questions again, Colin. The only thing I would say, although I think Charlie's explained this very well, is that we did set out to have as many complementary and to some extent contrasting consultation approaches which that we carried out during the consultation. So we fully expected that there would not be one single source of the information or perspective in the consultation analysis. So I think what you'll find in what is a very thorough and detailed report is that some often complementary views, but often in some cases quite contrasting and different views. And I think that makes it all the more important, I think, for the governing bodies to consider that in some detail as one of the pieces of evidence that they need to consider. I don't think we would have got consultation best practice, which is quite a difficult thing to achieve, if we hadn't pulled out the stops to do lots and lots of different bits of work to give us the information that we needed. And I think their report, is testament to the fact they've looked in a lot of detail across all of the information and not just one particular strand.
Yeah.
Okay, thank you, Andrew. Do colleagues, councillors, wish to say anything else? Ask further questions?
I've got one or two questions.
Yeah, please come in, Peter.
Well, one of my questions is, has the provider impact assessment been finalised, and when will the full report be published?
So I wonder, Peter, whether we can pick that up under the next section when Brian gives us an update on the integrated impact analysis.
Yep, we should be. Yeah, that's
because it fits in that section.
Right. Is it the intention to produce an indication of the changes that the programme intends to make when it comes to the final business case, in the form of a "you said, we did" table?
So I can confirm that that's one of the things that we will do in the decision-making business case, Peter. But I was going to say a little bit more about the link between the consultation analysis and the decision-making business case in my sort of response to the consultation report, which I think is the next item.
Okay, I'm jumping the gun. You appear to be telling me to just wait and all will be revealed.
I think the next agenda item, Peter, is for me to give a
no, this is Andrew, we're on it now. We're on 6.2, which is your agenda item.
Okay,
the next
so
one after that is 7,
report,
which is the impact assessment.
Yeah, so I'm going to give my report, if that's all right.
Okay, I'm happy for you to give that, and then we'll come back on questions on that.
Yeah, no problem. So just in summary, for members of the committee, I just wanted to put on record that following the consultation closure on the 1st of February, we wanted to thank everyone who took their time to listen to our proposals and then respond either online, on paper or face-to-face. And also to put on record, I think, thanks to Opinion Research Services and the other delivery partners for their thorough and detailed analysis. I think we've already made the point, I think, about the fact that the Consultation Institute gave us best practice. We think that's important to note for the committee. The consultation analysis is one of a number of pieces of evidence that will be used by the clinical commissioning groups, and in particular the governing bodies, to inform their decision making process, but very, very important for us to consider the report and the analysis. We are in a process of deliberation at the moment and giving full consideration to the findings of the consultation and any new evidence that will form the decision making process. We've been meeting regularly since the consultation report was published, and indeed prior to that, in terms of any emerging findings that were shared. And you'd expect me to say, I think, that there are a number of key areas where the CCGs have agreed to reflect further on the themes and issues identified. In some cases, undertake further work to look at those themes and issues before we make a decision. Although it is still our intent to make a decision on the 3rd of July of this year. So just a few words about the ongoing work. I think Peter and others have mentioned already that one of the key areas of interest is clearly around the impact of COVID-19. And it's an area where the bodies are keen to understand further what the emerging impact might be of COVID-19. We can't conclude necessarily and have a full picture about what that means, of course, because we're still going through the pandemic. But what the governing bodies have asked is that the programme conducts a high-level strategic review, which we've commenced, of COVID-19, and to reflect, with the Trust's help, on the learning to date of COVID, what we think the likely impacts may be. That may be around future capacity and the flexibility of the specialist emergency care hospital site under each of the options, and indeed the district hospital sites might be in terms of capacity, and to further consider this prior to decision making. So as part of those deliberations, we will need to think about what that means and whether or not there is further work that we would want the Trust to do in due course following decision making to further refine its assumptions, whether that's around beds, ways of working, or indeed other matters. But that work has commenced. There are a couple of other really important areas that we've sort of touched on already. One is that we need to give some further consideration to issues around access and future bed numbers. This includes one of the key points that you'll have read in the report, in that we were asked to consider extending out our modelling time frame to 2029-30 rather than 2025-26 to look at what that may mean in terms of beds. That's a piece of work that we've commissioned and is being discussed at the moment with our clinical colleagues, as well as probably the biggest issue that came up during consultation, which was around travel and transport. And again, there will be a number of key actions, I think, that we would like to potentially detail in the decision-making business case for the Trust to consider. And we will, I think, in response to Peter's question, want to be clear on the link between the themes identified in consultation and what our proposed actions are going. So I think those are some of the key areas that we are working through at the moment. You'll also be aware that the next item on the agenda covers an update on the integrated impact assessment, and in many ways, without sort of stealing Brian's thunder, we have been going through a process with their help independently, to update the assumptions, which include the provider impact assessment, although that's not been a new stream of work compared to some of the refresh areas that Brian will talk about in relation to looking at deprivation, and also refreshing some of the travel analysis that they did in the phase 2 of the report. So there will be a "you said we did" in the decision-making business case, and we will reflect and are reflecting on what some of those mitigations will be. So the final point I just wanted to make by way of an update is to say that we are taking, as you would expect, all of the information that we received very, very seriously, having lots of discussion about it, and what we are developing is a draft decision-making business case that will be put to the committees in common, planned for the 3rd of July, with a view to a recommendation about future service change. And we are, as you would expect, very keen to hear the views of the committee and to reflect on those once you've concluded your work by the 19th of June as part of those discussions.
Andrew, thank you very much for that. Could I just come into something you referenced, and Peter initially brought it up, and this is about COVID-19. You're doing another piece of work around this, and you said this would go to the joint committees. When are we likely to see that? Because we've been asked to make our representations, our final representations, by the 19th of June. And I think my other colleagues and myself would quite like to understand how that might impinge or change some of your thoughts. So I would be asking you, as the chair, when could we have sight of that?
So we are not planning to publish that prior to decision making. We've got a number of streams of work that we've commissioned, which includes the COVID response, and that will be one of the considerations that we will need to think through prior to decision making. But it's not the only thing that we are needing to consider as part of the governing body's work. As I've said, we've just published the integrated impact assessment. You have it in draft form. There's a whole number of things there, and some of this work. So what we're not doing is I'm publishing a separate document before decision making, but we will make clear in our decision making business case the analysis of the work that has been concluded.
I fully appreciate that you are working with the CCGs, but us as councillors on the scrutiny committee also need all that information to make comment on those final decisions. And to say you're not going to publish that, certainly I think as councillors, and I'm happy to take a steer from my other colleagues, but because it's so fundamental now in the short, medium and probably the long term, I think we need to have an understanding of what COVID-19 and any similar pandemic might have an effect on the decisions that the CCGs make.
Could I come in after that as well, Chair? Thanks.
Yeah, and me, please.
Yeah.
Bill Chapman.
So with the meter first, please.
Allow other colleagues, if you like, from the CCGs to give the view. But so I would reiterate that it's very important for the CCGs to consider COVID as an important issue, but it's not the only issue, and it shouldn't necessarily be the only issue that defines what the final position is in coming to a view on a preferred option, or indeed what the response to that will be. We will not have concluded, Colin, the work on COVID. What we're trying to do is a high-level strategic review that will come up with a number of interim findings about the learning to date, what we think the impact might be, and we will have to make sure that the governing bodies have thought through that as part of their decision making.
Okay, thank you. Before we are...
Thanks. Sorry, Chair, did you want me to come in with my comment? Chair, did you want to come in with my comment?
Sorry, yes, please.
Thank you, Chair. Andrew, I think it was just a comment that I wanted to make, that obviously in terms of process, scrutiny process, obviously there's an absolute link between the final independent impact analysis, obviously, and the mitigations, suggested and recommended mitigations that you then will take forward to inform your decision making. That I completely appreciate at this stage. I just wanted to say that in terms of my own view on one aspect, which was that obviously travel times and journey times to any new acute hospital. In fact, travel times overall. I think just the point I wanted to make really was that I'm interested in, obviously, in all of this, in the risk mitigation. So when you come to look at the detailed reports, you know, the high level reports that you're doing on COVID and on the other work streams, I really just wanted to say for the record that I'm obviously specifically interested in looking at what actions you're intending to do, you know, with the information and analysis that you are going to then receive. And I think that's a really important part of that process. As you say, you have to go away and you have to reflect on that. But in terms of scrutiny, I think it's going to be particularly interesting to see how you've acted on the draft recommendations, and also what decisions are you likely to make in order to complete your findings and your report, and also what you intend to do in the future, and also whether your perceptions have changed, and whether as you look at backwards, if you like, at your case for change, whether there's a difference in your perception for any aspects of your either your business case, or I'd be interested to know whether that was going to be impacted, or are you looking at other aspects of this proposal where it's just going to be centred around the site issue. So I just wanted to make that as a comment, really, with a little bit of a question at the end. But that's really what I wanted to say. Thank you, Chair.
Okay, thank you. Do we have any other colleague who wants to talk? Sean, yes, please come in.
Yes, please, Chairman. Yes, please, Chairman. It's Councillor Chapman here.
Oh, Councillor Chapman as well. Councillor Chapman first, then.
Thank you.
Sean next. Okay.
I think Peter also wanted to speak.
Yep.
Okay.
Yes. Yeah.
Bill, Sean, then Peter, please.
I'll start. Shall I?
Yes, please, Bill.
Okay. Thanks, Colin. Yeah. I think my question centres around what further documentation we'll be receiving in really over the next week or so. We're going to have to put together our response in Surrey Heath by the 12th of this month to feed in for it to all be put together into the joint HOSC return. So are we going to get anything more? So, for instance, a more complete version of the integrated impact assessment, and also anything on the investigation into COVID, please. You know, for instance, if it's just something quite simple would be very welcome. Something that says our investigations to date indicate that there's no impact that is likely to make the recommended approach invalid. That's
Thank you,
my
Bill.
question. Thank you.
If we go on to Sean and then Peter, and then if officers, NHS colleagues could come in on that one after the two colleagues have said something. Sean, would you like to come in? Sean, you're on mute.
Sorry, okay.
On mute. Okay, you're back.
I've unmuted myself. Okay, I just want to put on record my unhappiness with that response. I note that within the gender paper, it talks about that there will be that the CCGs will consider other evidence, and I was quite interested to understand what that would be. But clearly, the world has changed. COVID-19 is not something like even like the financial crash. It is a combination of a financial crash. It's a health epidemic, and it has a number of other, and we're going to have an economic impact as well. The deadline that we have to give a response to in a couple of weeks' time and then you're going to make a final decision by early July, does cause me concern if we're not able to see those papers that are going to inform your decision. I'm just looking through the guidance on health scrutiny about referrals to the Secretary of State, and I do have a concern that we are not provided with all the relevant information for us to make a final judgment about this. So, I just do need to understand why yourself and the CCG haven't felt fit to either defer by a week or two to give us some extra time to consider the evidence that you're considering, or if that work has been undertaken already, to pass it on to us.
Thank you, Sean. Peter, if you'd like to come in, then I'll ask NHS officers, the appropriate officer, to respond.
Well, I think just to follow up on the point that Sean made, I'm astonished to hear the programme director saying that they intend still to make a decision by the 3rd of July. And yet, there doesn't seem to be any recognition that the world has changed. And my question is the case for a single, smaller central site with less major acute beds, less doctors, less qualified nurses, and one less A&E department robust enough in the light of COVID-19, given the social, economic, and health impacts are not fully understood? And would it not be better to pause and allow re-analysis of the impact on local communities, starting with the new Joint Strategic Needs Assessments overseen by the Health and Wellbeing Boards in the affected areas? And I come back to, the issue of deprivation. And the question I find myself asking is, I come back to paragraph 4.22, residents in the black and ethnic minority backgrounds and the most deprived areas are most likely to say it will be easier to travel to St Helier Hospital. Do Black Lives Matter? Are you listening to the views of that community? Are you taking into account the needs of deprived communities? And do you not recognise that those that are currently in poverty are likely to be going into extreme poverty, and people that are, not doing too badly, doing okay, or were doing okay, are now going to be pushed into poverty? And yet you are proposing to continue with the runaway train and not pause and not consider that the world has fundamentally changed in the last few weeks.
Okay, thank you, Peter. Thank you. There are some specific questions to answer, I think, on this one about around COVID-19. There's also some more general questions about equality, etc. So can I ask one of the NHS colleagues to answer?
So it's Andrew Murray. Hi, GP Chair of South West London. I'm also the clinical lead for COVID for South West London. So it's probably appropriate for me to pick up the question on COVID as much as I can.
Thank you.
What we have been doing since COVID started is a huge amount of work on data. So we've been looking at the data we've got from general practice. We've been looking at the data, excuse me, that we've got from hospitals and from 111, and we've been using a tool that we've developed over the last year called a population health management tool that allows us to look at our population and what's happening to it. And what that information tells us is the spread of the impact of COVID in our population. And what we can do then is we can map the impact of COVID against deprivation and ethnicity, and also other underlying health conditions. So it's giving us some really rich information, and we're ahead of all the other parts of London in that, and in fact in many other parts of the country. What it tells us is very much in line with what you've seen published in the Public Health England report this week, which is that there are excess deaths and hospital admissions from COVID in particular at-risk groups. So that's in deprived communities, in BAME groups, in older people, in males. But what's particularly important about the data is it also starts to give some indication as to why that is. And when we look at those groups, what we also see is they have a much higher incidence of underlying health conditions, such as diabetes, obesity, cardiovascular disease, and hypertension. And we see that link really clearly when we look at the data using this tool. It shows us that in those groups, there's a disproportionate impact of those underlying conditions. Now, what we know from the science so far is that it's those underlying conditions that increase your risk of becoming significantly ill with COVID. So what that tells us about the solution to the problem is we need to be doing work on obesity, on cardiovascular disease, on diabetes, on hypertension. And that very much fits with the strategy that we have already set out as a system, which is to try and invest in out-of-hospital care, particularly in prevention, in health promotion, because we know that it's the work through the health and wellbeing boards in the out-of-hospital space, and not just around health, but around environment, around healthy lifestyles, that will really make a difference to these factors. Sure, we can do a lot of work in general practice to improve the care of some of these underlying conditions, such as diabetes, hypertension. And we particularly know that for diabetes, if we manage that effectively, we can probably reduce the impact of COVID on those groups. But that's the only long-term condition where we have evidence that immediate action on that condition will improve outcomes. The real problem here is deprivation and health inequalities, and the answer to that is the out-of-hospital work we're doing in all our boroughs across South West London. We really must focus on that.
Okay, thank you for that, but I don't think that answers really the question that we put to Andrew. I think it's us as the scrutiny committee for South West London wanting to have all the information before us. So we thought that we would have all the information, the majority of it. We now have a new scenario where we have COVID. And what Andrew is saying is that the decision makers at the CCG will be presented with information, but actually elected councillors won't. So what we need, and what my colleagues are saying to me, is that we really should be able to have as much information as possible. There is a question of COVID, and that's why we're meeting as we are. COVID has changed the whole daily life, the future, etc. And if you are CCGs are making that decision with that evidence in front of you, why shouldn't we as the elected representatives have that information before us so that we can comment on any decisions that you make?
Hear, hear.
Colin, can I just come back to you just on a couple of things?
Yes, Andrew, that's fine.
I'll respond again to your point. So I just want to respond to Anita's sort of questions about sort of risk and mitigations. I think it would be helpful to hear what Brian's got to say about the work around that the committee's done in terms of updating the integrated impact assessment, of course, because part of that will be, and we'll publish that report early next week. It goes to our internal IHT board next week. That will detail two things which I think are important. One is a range of things that we should consider as part of our decision-making business case in terms of mitigation. It will also, I'm sure, for those that have read it, also indicate that we need to consider the issue around the future resilience of our proposals going forward. But what we won't have done by then, by the time we make a decision, is conducted a full social, economic, a full social and economic, or indeed financial impact around COVID. What we will have done is consider what we think are some of the most important things locally for us, both in terms of, I think, any mitigations that I think Andrew's alluded to that we should focus on further, which isn't about changing the acute hospital model necessarily. In fact, I think there are arguments that can be made that what COVID has highlighted is even more, I think, the need to bring together our specialist clinicians to provide specialist emergency care in a centre, but that we will have considered some of the wider issues. And we think the most important thing that we need to reflect upon further is around the future flexibility of each of the sites to cope with potentially other pandemics going forward, and what resilience there is. But we won't have concluded summatively an analysis of every single thing that needs to be considered. Nationally, they haven't done that. Regionally, that work hasn't been concluded. And I don't think it would be fair necessarily to expect the programme to have done a wide-ranging, comprehensive and exhaustive analysis. But what we're trying to do is pick out what we think are the most important factors which may have an impact on those proposals. And we'll lay those bare in the decision-making business case. But it's a live process, and evidence is coming forward as the Trust does its internal work before we're able to make a decision. But our intent is still to produce a decision-making business case that includes that high-level review. But it will still be a preliminary level of analysis.
Okay, thank you, Andrew. My colleagues are unhappy. Thank you, Peter. Hold on.
Colin, can I just respond to that point?
Evidence to be set before us, even if it's your initial thoughts, etc. What we do have is the process where the scrutiny committee is there to represent the residents, and it is a changing scenario. And you are saying that you are in the process of doing it. We can share information as we have done in the past. So I think there needs to be some thoughts around sharing information with members of the scrutiny committee in order that we can be as brief as possible when we present our conclusions on behalf of our residents.
Colin, can I just come in with a point relating to the last comment?
Yes, certainly.
I mean, I couldn't see, or I didn't know who that was, but was it Andrew that was talking? Yeah. Was it?
That's correct. Yes, that was me, loud and clear.
So there was a reference to resilience of services, and it brought me back to something that was said about the resilience of services in some of the documents we've seen before. And let me quote, "A reduction in the number of hospitals providing major acute services could potentially have a negative impact on the resilience of services. If, for example, there is an unplanned event, such as an electronic virus affecting the hospital system, a fire, or an outbreak of norovirus on the single major acute hospital site, which may restrict service delivery. It is recognised that the likelihood of such a situation occurring is unlikely." Now, it seems to me that has been demonstrated to be completely wrong. And what irritates me about the attitude I'm hearing is Colin has made it clear that elected representatives have the right to see the evidence that you are looking at. And it's almost as though you are saying, there, don't you worry. Don't you be your pretty heads about it, because us professionals know best, and we will consider the evidence in secret and make decisions, and we won't share the evidence with you, and that's unacceptable.
Okay, I think I'd quite like to ask for a clinical input here. James, did you want to come in?
Yeah, thank you, Councillor. It's James Marshall, the Medical Director at Epsom and St Helier. I just thought it may be helpful to provide a little bit of context of what it felt like working in the acute trust during the peak of the epidemic. What was clear is the acute services that we know are least resilient were those services that were under the most strain. So our emergency department and our intensive care departments were under the most strain, and we needed to redeploy staff from lots of other services. So we had orthopedic surgeons who were working in our intensive care unit, and they were working as nurses and support workers. We had to step down outpatient care in order to sustain the emergency department and the intensive care unit and the medical wards. So what we recognise at Epsom St Helier is that we are constrained by running parallel services on 2 acute sites, and there's definitely a benefit in giving us more resilience if we can consolidate the acute services on one site. The second observation that we had related to infection control, and in an ideal world, any new admission would have been admitted into a side room until we knew their COVID status, and then they could have been cohorted appropriately on a COVID ward or a COVID-free ward. And we were limited by the number of side rooms that we have at both the Epsom and St Helier sites. So we needed to cohort patients on admission by a clinical risk stratification rather than in protected, isolated rooms. And then the final observation that I'd make was actually there was very effective cross work between secondary care, primary care and community services. So a lot of patients who would have had a long length of stay, we managed to discharge effectively for onward care in the community. And that's a really strong learning lesson from the COVID era. And through March and April, we were maintaining services with about 200 empty beds across the 2 acute sites.
James, thank you for that. I am conscious that it is now 9:10, and we need to move on. We have some important items. We've got 3 very important items, 4 actually, and we have to stop at 10:30. On behalf of my colleagues, I will take this up. We will take this offline. I know we still have major concerns that we are not receiving information. It was good to hear James's view from a clinician, but I do think we need to take this after this meeting so we can cover all the important parts. But I will be talking to Andrew and my other councillor colleagues on how we can be furnished with all the up-to-date information as best as possible. We're not asking for chapter and verse, we're asking for what you are doing at the moment and what your thoughts are. So colleagues, I do think we do have to move on. I'm sorry if somebody wanted to come in, but I'd like to move to item 7, which is the update of the integrated impact assessment.
Okay, thank you very much.
That's Brian, isn't it, coming in?
Yes.
Yes, sorry,
Yes,
Brian. I was just looking at my notes. I'm working off 3 screens. Sorry, Brian. Over to you.
All right, so hopefully you can see the presentation in front of you. What we thought it would be important to do was to provide the JHSC with an update in terms of what we have been doing in terms of finalising the integrated impact assessment report. You may remember that we produced a draft interim impact assessment report prior to consultation, and we always said that we would come back and we would look at that report in light of what was coming out of the public consultation and update the findings. It's fair to say that it's also given us an opportunity to refresh some of the analysis, some of which Andrew has previously mentioned to you. And the idea is that the integrated impact assessment report setting out the potential impacts and also the mitigations can be used then by decision makers for their decision making business case process. The main principle of wanting to finalise the impact assessment report now, post-consultation, is to have a review of what is coming out of the consultation findings and to be able to triangulate that feedback with the feedback that we got through our own processes and activities through our focus groups, to see where the extent to which there is alignment and agreement in terms of impacts that we were previously identifying through the impact assessment, but also to see if we can gain new insights and try and understand more from particular communities, either those living in higher levels of deprivation, older people, or some of the seldom heard or hard to reach groups that the consultation processes may have managed to find more insights in terms of what potential any of the options might have on those. So what we have done is gone through a process of reviewing the consultation findings. So that's the consultation report that Charlie has already presented to you on, but also looking at some of the background material as well that underpins that report, and looking to see how and where we can weave in some of those consultation findings in terms of any new evidence within our own report. We've also had the opportunity to have a look again at deprivation analysis. There was a request through the consultation process from Merton Council where they were keen to understand what the association was between different deprivation levels within their community and the use of hospital services. And so we agreed with Merton Council to have a look at that analysis, but we widened it up to make sure that we were covering all 3 CCG areas. And what that analysis shows you is that there is a high correlation between emergency department attendances and levels of deprivation. But when you start getting into looking at medical and surgical admissions, there's a much weaker association between higher levels of admission with higher levels of deprivation. That the council were also keen as well to understand, do people in more deprived areas have longer lengths of stay, and the knock-on impact of that being, you know, in terms of families and carers having to come to the hospital if these patients are in proportionately longer. And so we looked at length of stay as well in relation to deprivation, but again couldn't identify any observation that would link the two. You may recall that within our impact assessment report, we do look, when we look at the various impact areas, we look deeper into some of those and understand which groups or which populations may be more disproportionately impacted under each of those impacts. And a lot of that data, when we start looking at deprivation, relies on the indices of multiple deprivation, which are released by the government. And during or at the beginning of this year, the government released a new data set of indices of multiple deprivation linked to the lower super output areas. And so we have gone back through all of our analysis and used the latest information to make sure that we are providing the IHT programme with what is the current position, rather than relying on some data that may be slightly older. It only has a marginal impact. You know, there are no big swings in terms of deprivation across different sort of quintiles. So there's no big swings in any of that. But it is important that for us as a process, in terms of undertaking the impact assessment, that as I say, we do use the latest information, just to give you a bit of a feel about where some of those changes happened. If we look at Merton CCG, there has been a slight change in terms of deprivation quintile 1 is the most deprived areas. The previous data we were looking at had 4 lower super output areas in that most deprived area. That has now moved to 3. There's been no change in the Sutton CCG locality, and Surrey Downs previously didn't have any in the most deprived quintile and still continues not to have any, although there has been a slight change for them in terms of the second most deprived quintile, where they've seen a small increase in the number of LSOAs and populations falling into that category. So as I say, it doesn't make a huge impact, but it is important for us as part of the process to be using the latest information. And that is also true of travel and access. You know, as you heard through Charlie's presentation, and as we heard through our own focus groups, travel and access is a big issue when you consult and engage with local people. And the data sets that we were using previously have now been updated. So there are new national data sets for private car that relates to data captured in 2018. And for public transport, it's data related to 2020. And so we have gone again back through the report and updated the analysis using that latest, those latest data sets. As with deprivation, it doesn't change the sort of outputs and the findings significantly. There is a small shift, but overall we're still seeing the same overall proportions of patients locally accessing services within 30 minutes by private car as we were within the previous analysis, but in the shorter time bands, looking at 0 to 15 minutes or 15 to 20 minutes, there have been some small shifts in those travel time bands. And for public transport, there has only been a slight difference in the proportions accessing services within those particular travel time bands. So as I say, we have updated the analysis within the report, but the overall message within our impact assessment report remains as was. And as Andrew has previously spoken about, we did previously have a section on resilience, and it is true that we thought these were never events, but things we might want to talk about. COVID-19 has set that now in a new light, and the challenge it presents to the NHS in terms of managing future surges in capacity. And so we have now gone back and redressed that statement around resilience and about the need for future flexibility and adaptability in the structure of what is designed and developed to ensure that there is enough capacity to manage that in the future. In terms of where we are, so the report that has been issued to members was prior to the steering group meeting, which we had on Monday this week. So in terms of the revisions that we wanted to make to the final IIA report, we agreed those with the steering group at the end of April. And then we sent a draft final report to steering group members on the 20th of May and gave them until the end of May to come back with their comments. And on Monday, the 1st of June, we met with the steering group members to go back through their final comments and see whether or not they had any further comments about our impact assessment report, which we discussed at the meeting. and we have now reflected those and now given the IHT programme our final report. Just as a way of an update, there were 2 or 3 things that were discussed at that IIA steering group meeting. One was around the impact on providers, and steering group members wanting a form of words that talked about funding being committed to increase or to ensure that the whole system was able to respond through the IHT programme. So we have provided that as a further statement in that section. And under the resilience, we have added a further additional statement that says if there are any updates to the programme or to the wider healthcare system, then the impacts should be reviewed and reassessed. So they're probably the 2 main actions that came out from our final meeting with the steering group members. So I will leave it there, and thank you very much, and happy to take any questions that anybody might have.
Yes, excuse me. Before we come in there, could I just say to colleagues, because of the timing, could I give 15 minutes for this? We were going to have a break. I'm sure colleagues can work in their own comfort breaks if they need to. And if we could give about 15 minutes for this item, and then we have at least another 2 major items and the public representations for information. So colleagues, if you want to get through the agenda, let's be precise and drive into the detail.
Thank you,
over
Chair.
to you, Anita.
Thank you, Chair. Brian, thank you very much for what I have feel has been a very detailed report, very thorough report. And I really just wanted to, there are so many areas that I could zone in on, but I'm going to choose one particular area. It's to do with maternity in the paediatric side of the service that would be proposed to go to the any new acute side. So I just want to start off by saying that obviously the impact assessment that we have now obviously clearly demonstrates how travel times and distances can vary depending on the mode of transport available. So that I felt did come out very much from the data. And looking at the analysis and looking at the impacts on travel times for different communities coming from different locations. For me, I'm particularly interested in understanding what the material and disproportionate changes would be for certain people. And so if I can zone in on one particular area, it's about the impact on maternity and on the families that surround individuals. So it's not just about looking at the importance of travel outcomes between sites or to any acute site. It's about making that distinction and being clear on the on anything that moves from a marginal adverse to a moderate adverse, particularly if you're looking at differences and the distinction between blue lighting and car and visitor. I felt that was very, very well done in the report, but it still threw up questions about, not so much about individuals, a pregnant lady or a girl or lady person who is pregnant and perhaps will be blue lighted. It's about the issues about visitors and the families surrounding individuals. So my question really from the data, if I can find my question, here it is there any data on the number of maternity admissions which need stepping up? Because clearly, if there's a distinction with maternity moving to acute site, which I do understand the rationale for that from what I've been reading, being an acute service for birthing, but if you've got if you can say, well, there's no absolute change in journey times for pregnant individuals who are obviously blue lighted or going by car. My concern then rests with those that are either not going by car, and there may be cases where individuals would then have to rely on public transport. It'll be rare, but it might happen. So my question is, what sort of data is available that gives you an idea of the impact on a maternity admissions which need stepping up? So individuals who, for whatever reason, might go to a district hospital and present there, but really should have gone to acute, or the other way round. I'd be interested to know your thoughts on that. Thanks, Brian.
Okay, thank you, Councillor. When we've looked at travel and access, and we've looked at what does it mean under each option, under the particular modes of transport, we've looked at it at an overall population level, but then have been keen to understand what that means for different types of communities or different protected characteristic groups, and one of those is around sort of maternity and pregnancy, and about looking at where is the distribution of women of sort of childbearing age, and do they have a disproportionate impact in terms of accessing services compared to the overall population under each of those options. And that is probably about as far as we can go in terms of the quantified data analysis for that and trying to understand it. We did, as part of our own process, undertake focus groups, which did include looking at that particular cohort of people and trying to understand from them their experiences of maternity services and what it might mean in the future under the various options that being considered. And we have, as part of going through the public consultation findings as well, picked up the issue, which I think Charlie also raised as well, in terms of the separation of care between the sites, and some of the decision making that potentially some people might make in terms of not wanting to travel further and go to a particular site, but actually elect for a home birth, which may not have been their particular choice. Now, that's not everybody, and it's going to affect different people's views under different options. But hopefully we have got the balance right in terms of our impact assessment report to be fair in terms of how we are representing those various views.
Thank you, Brian, for that.
Sorry, Brian. Let's have a look now. Yes, Sean, would you like to come in?
So, thank you, Chair. In regard, looking at the Mott MacDonald report on, I hope this is where I am on page 554 or 111. 10 of the actual report. I looked up the issue of the resilience of services, and 5.94 in that report. There may be varied impact of resilience on major acute services, and my understanding from what was said to us just now is that the resilience part of the report has been updated. Is that correct?
Yes, it has.
Right. Okay.
It has, and that, as I said at the end of my presentation, there has been a further additional statement that has been made into the report that you won't have seen because it was agreed with the steering group on Monday, which was about if there were any changes or system-wide changes or program changes, then there would be a need to potentially come back and review some of the impacts.
Okay, so the problem that we've got is that we can only make judgments really on the information in front of us, and we don't, and we can have reassurances, and but I know from our own discussions in our local council, for example, that people are looking in terms of sort of office capacity, which is clearly will be a part of the issue the hospitals have regarding their sites, that there's much reduced ability to actually have people housed on site to work. But just reading 5.94, a reduction in the number of hospitals providing major acute services could potentially have both a negative and positive impact on the resilient services. But then goes on, there's an unplanned event, including one of them, which is an outbreak of a virus. And we know outside, where most people have died has been in hospital. And, I do think that if resilience of services is an important enough subject for you to revise it, this committee needs to see it before any judgments can be made. Without the evidence of what the response or the suggestion from McDonald to the board and how they then consider it, I feel that I'm sort of making a judgment without the full facts.
Sure.
Is there a reason why you can't share it earlier or quite quickly?
Just to say, what I think from my point of view as the chair, I've listened. I think what we'll do is take this offline. I'll talk to CCG colleagues on this one, senior officers, and I'll come back to councillors. But I do think the feeling, as NHS colleagues will have realised, is very strong about having meaningful information. I'm conscious of the time, so I will take this on board with the accountable officers of the various CCGs. Has anybody else got any questions for Brian?
I've just got one more, Chair, if you don't mind.
If you make it quick, Anita, that's good. We're pushing on.
Thank you. Brian, my question is, as there tends to be a higher prevalence of long-term conditions in more deprived areas, is it the assumption that attendance could increase for this cohort under the new model? So if there's a district hospital model, are there any inferences that can be drawn from the data that could answer that question? Thank you.
Sorry, Anita, are you just able to repeat your question?
Yeah, of course. As there tends to be a higher prevalence of long-term conditions in more deprived areas, I believe I've had that information from the deprivation analysis. Is it the assumption that attendance may increase for this cohort, so people with long-term conditions, under any new model? So there's a district hospital model, rather than individuals going to presenting at A&E or to acute hospitals. Is there anything in the data that might suggest that that would be the case?
Well, I suppose the whole sort of district services model is particularly aimed at those with long-term conditions and about taking it across the whole pathway around looking at prevention before you get into the sort of primary and community care services, but making sure all of that is integrated. And I think, to me, that is what the IHT programme are promoting in terms of that district service model.
So I think my question would therefore be that under the new model, there would be, based on the data you have, you'll know how many people are presenting at acute hospital sites for conditions that they may well, in the future, go to an urgent treatment centre for. Is that coming out at all in the impact assessment?
So that's not really our work. The sort of modelling work has been done by the programme, but what you are saying is exactly right. What the programme have done has looked at historical information and activity patterns, looked towards the new model of care and translated what that will mean in the future about people being able to use alternatives, either through the urgent treatment centres or through what do you do to enhance and promote more that sort of health promotion and primary and community care services that then takes or negates people ending up actually at A&E or becoming an admission.
Okay, thank you, Brian.
Okay, colleagues.
Colin, I was trying to ask a question.
Oh, sorry, Peter, you're not. Yeah, carry on quickly. Yeah.
Very quickly. Brian, when I was reading section 594, I read a paragraph earlier on, and the wording is different. When did you change the wording of this paragraph, and are you about to change it again? That's my first question. And the second one is, do you feel, are you confident that the model that you've based this on will have a beneficial impact on health inequality? The Marmot review concluded in February that the health gap between wealth and deprived areas has increased and life expectation has gone down, life expectancy, and that was before the additional impact of COVID.
Okay, so I suppose I'm not entirely sure which version of the report you are looking at, Peter.
Well,
so it
says, and I quote, "It is
okay.
recognised that the likelihood of such a situation occurring is unlikely." The wording has changed. When was it changed?
So that was changed as part of the general refresh that we have done and agreed with the steering group. So, you know, through my presentation, that these were the areas that we agreed with the steering group members that we would go back through and refresh in terms of our report.
But you just said that's only done this week.
So we have.
So you it twice.
Sorry, say that again.
You've changed it twice because you're saying it's been changed again this week, but the version that we've got in our papers was issued before your meeting of the steering committee.
Yes.
And it's different to the original.
Yes, it has been updated twice. So we updated the first time, we have shared it with the steering group members to get their comments on it, and it has been, as I say, slightly amended since. So yes, the paper that you would have had will be a slightly older version of where it would have been relevant, and it would have been most up to date in terms of issue papers to the JHSC committee. But in the last week or so, we have been revising and finalising that report.
Again, colleagues, Peter, thank you for that. I think what I'm hearing is that there's a lot of learning for us as from a council side about understanding when things are going to be changed and having up-to-date information regarding refreshes, as it's put, because we are not aware of those dates, and I think we needed to be aware that what could be in the pipeline. So Andrew, did you want to say something? Then I'm quite conscious about moving on. There's two other important items.
So the thing that's really important is that all the work that Brian and colleagues have been doing has been shared with relevant officers as we have proceeded throughout. So we have been in contact and dialogue through Brian, through Andrew George, directly with Mike Robertson at Merton, who has reviewed line by line the work that we have done and exchanged correspondence. So I just want to reassure colleagues that we've been working through a process that we've published, including the, and that officers have had the time and indeed have responded appropriately directly to Mark MacDonald. So there are no smoke and mirrors here. Just want to be clear that we've done this in accordance with the timetable we set out, and officers have been involved, and we have a written record of the exchange.
Can I just clarify, when you say officers have been involved, that's the officers that service this committee?
Members of the steering group, as agreed with the representative local authorities, so public health representatives, Mike Robinson from Merton, but there are others that have been involved as well, so agreed representatives who are members of the IIA steering group have been involved as previously. So that has not changed.
Okay, I think what I'm going to do is review this with my officers and my councillor colleagues. I think
Colin, they haven't answered the question that I asked about the Marmot's report.
Okay, can someone answer that one very briefly? It's now 9:45 and we've got to finish at 10:30.
So in terms of the overall future model of care, I mean, yes, we have made a statement within and have a section on health inequalities in our report. We are very clear that, you know, healthcare services in their own right are not going to address health inequalities, but the proposal of the district service model, along with other contributing factors, can really help support health inequalities locally in terms of services. But in its isolation, the district model services, you know, it isn't going to do all of that itself. It needs to be a much more coordinated, integrated local response with other agencies.
But when I spoke to Professor Marmot, he said that that's one of the few things that you actually control, and you are making a decision to move services away from deprived people.
Colin,
give me 2 minutes. I need to push on.
Yeah, so I think we have a difference of opinion, Peter, on this issue. I think what's described in the independent integrated impact assessment, and indeed in the deprivation study, is a recognition, I think, that there is less evidence to link the location of acute services with deprivation, and I think that's a different point. I think what Brian is saying is that health has a role in partnership with local authorities to try and reduce health inequalities, that most of the activities that need to take place, which I think Dr. Murray remarked upon earlier, are about making sure that there are appropriate interventions earlier in the pathway through both the district hospital model and indeed broader primary and community services. There is a less clear link between the need for acute services and the location of acute hospital services.
Okay, thank you, Andrew. Colleagues, I'm sure councillors will take this offline and we will come back to colleagues. I'm conscious that we've got item 8, which is public representations. And for me, we did ask for this. It's something that I know scrutiny committees want to engage the public, and we haven't been able to because of the crisis. So we have these written representations, and council colleagues will take these into account when we produce our response on the 19th, or by the 19th. Does any councillor want to make a quick comment on these, or are we happy to use these as part of the evidence from our electorate and move forward to item 9? Anybody want to speak? No? Okay, thank you very much. Could we move forward to councils and consultants' comments on this one? And I think we have a representation from Robert on this one, isn't it? Sorry, item 9. Roger Steer.
Yeah.
Are you there to give us a... I'm sorry to keep you waiting. What I'm going to do is we need to finish this just before 15:15, or about 10 past, if you don't mind. So you've got 20 minutes.
Yeah, I've got a presentation. Kathy was going to show up the slides. I don't know whether she's ready. Here it goes.
There it goes. There we go. If everyone can see that, that's fine.
Okay. Right. Well,
far away. So
thank you for allowing me to make this presentation. You don't need me to remind you. Local authorities have a legal duty to scrutinise and to approve or seek changes to NHS plans. In this case, the London Borough of Merton has sought independent expert advice prior to making a a formal response to the consultation. My report is available for examination and future engagement, and I will go on to summarise my findings. But my advice will be that plans should not be approved. COVID-19 has shown that the NHS lacks capacity and resilience. We still do not know the longer term implications, and all plans need to be reappraised. The case for it being necessary to cut beds, staff and spending has not been made reliably and safely, particularly now. And in my view, more time should be taken to look at other options and understand longer term requirements. My second slide, please. Is that there?
I can't see any presentation.
Well,
I can see the presentation. Can other colleagues see?
I can see.
it.
Yeah, I can see the presentation.
Yeah.
Well, can we move on to the second slide? Is it showing? It's not showing.
Yeah, we've got this. The second slide is showing now of your findings.
Right, okay. Well, my findings are, first of all, that the pre-consultation business case is both premature and flawed. Premature, particularly in the light of the COVID-19 pandemic, but also pending organisational changes, the institution of the integrated care systems, and prior to an adequate case being made. And flawed in respect of methodology, the multi-criteria analysis and option appraisal are both flawed in my view, flawed in its costings and analysis, and flawed in presentation. In my view, there's a prima facie case that the proposed reductions in A&E catchment areas, reductions in consultant staff, middle ranking and junior medical staff, and qualified nurses, and in access to major acute beds, are not in the interests of local health services. Clinical arguments in favour of increased centralisation are not borne out by evidence and experience. I've gone into that in some detail in my report. And nor is it likely that it will resolve staffing difficulties, which seem to be based upon non-local matters. My next slide, please. Does that come up?
Yep, the third slide's up.
Yeah. My next
I
finding
think
is
we're one behind, Roger. We need to get, and he's just talked about his findings. We need to put the next slide up.
now, well, access to one major site will be worse than the current two-site configuration, particularly for those reliant on public transport and for the deprived. I think the point's been made that it's the duty of public bodies to positively contribute to reducing inequality, not to make it worse. In my view, lower cost options should be considered, and claims that large savings are available independently assured. At the moment, savings seem to be entirely notional, based on an inappropriate baseline, unrelated to the option proposed, speculative and unreliable. In addition, there seems to be a risk of undercosting of the capital, and the public are likely to have been misled at this stage on the consequences of the plans presented, their true costs, affordability and impact on services. My recent experience in northwest London is that the NHS persists with unrealistic plans until told otherwise by external stakeholders such as yourself. It's difficult for them to accept groupthink exists, plans are biased and subject to vested interests. My fourth slide then raises the question, which I think has come up in the discussions I've heard, is why is there a great hurry to make a decision, and why the panic to make a decision? It looks like an attempt is being made to bounce people into decisions using the rhetorical device of an opportunity too good to question closely. In my discussions leading up to my report, it was said £500 million needs to be spent. Another motive seems to be to secure a decision prior to formal authority for local services being transferred to new bodies, the integrated care systems, which cut across the area that we're talking about here. A better way forward, in my view, is to take more time in looking at the options and to prioritise supporting immediate improvements to existing services on existing sites, and to listening further and engaging further with stakeholders and patients concerned about losing access to local services and were sceptical of NHS plans. And in my final slide, which I hope is in front of you, my recommendations are therefore to reject the PCB and the proposals as they are, and to call for further work on lower cost capital options for services on 2 sites, not 3, and to address staffing by seeking additional trainees, rota changes and incentives to staff to improve recruitment and retention. And then to reappraise the longer term priorities and the need for additional savings in the light of government intentions to respond to disquiet on NHS funding and the current crisis, which has exposed the lack of capacity and resilience of the NHS.
Roger, thank you for that. What I would say to colleagues is that this is almost coming across as a different proposal. Our constitution really is on this particular subcommittee is to look at the 3 proposals that have been set before us. We could reject, but I'm not so certain we could recommend we go for alternatives in the manner mentioned. That's just my view in terms of looking at how and why we were set up to look at the proposals of the current CCGs. But I'm happy for colleagues if they want to ask Roger any questions. Anybody want to come in?
Well, I'd like to say that we've commissioned in Merton this independent report from a person who's spent much of his life working at senior level within the NHS, and he has challenged many of the assumptions made, and it's been my experience at the listening events that we've had very lengthy presentations from the NHS colleagues that we've heard from this evening, and nobody's really been given an opportunity to put an alternative. And it does seem to me that there are a number of flaws with what's been presented. Many of us have talked about the issue of deprivation, and this whole race to continue and make a decision by the 3rd of July when things have changed so dramatically seems absolutely absurd.
I take your point, Peter, but on the other hand, some of the recommendations of this certainly wouldn't be under the auspices of this committee, and more actually to the point of the whole South West London JHSC, if we're looking at ICSs and various things like that. But I respect what Roger's put in his presentation. But as I say, I think it's a much wider option than the remit that this committee's been given. Yeah, but I'm happy to listen to colleagues.
What we are saying is not a million miles away from what the London Borough of Sutton has said. That our preference is that that the site should be on St Helier. That's what you've had to say, and that's what we're saying.
At the moment, you would appreciate I'm chairing this scrutiny subcommittee at the moment, and yeah, that's fine.
I realise that you are chairing the committee, and that makes it difficult for you to get involved in the rough and tumble of the debate. But I would urge colleagues to read what the London Borough of Sutton have had to say about this, and I welcome it. I support it, and I think it concurs with many of the views that I've heard expressed by the people of Merton, many of whom live, like many of the Sutton residents, live in the more deprived areas around St Helier Hospital. So I welcome what Sutton have had to say, and I would be interested in whether other local authority members take a similar view to Merton and Sutton.
I open it up to colleagues. I'm not sure whether silence implies assent or negative approach. It does appear, giving my colleagues the option to speak, that nobody requires to speak at the moment on this paper. Okay, thank you very much. Roger, thank you very much.
Yeah. Chair, sorry, I think Councillor Fitzsimons is looking to come in. I don't know if you could see him.
No, I can't. Thank you very much for coming in. Councillor Fitzsimons, would you like to come in? There's nothing on my screen.
I was just waving. I should really probably have shouted. Can I have a lot of sympathy for this paper, but I sort of do take on board the chair's comment that it is a slightly wider paper than the matter that we're considering tonight. But that doesn't mean that it doesn't carry some weight with me. You know, I welcome the opportunity to have read the work that Roger and the other additional documents that are listed under item 9, including things like the letter from the leader of Merton Council. But you know, I'm sure when we come to our own consideration, I certainly will have regards to it. But I do again want to stress that I have some other fundamental concerns that have yet to be addressed by the CCGs about the impact of COVID-19. So I'm happy to move on from this item, but I do want to thank the effort that people put in producing this report and submitting it to this committee, and to acknowledge the work that they have done.
Yeah, I would agree. Thank you very much. And as I said earlier, this is something that I'm sure will come to the full South West London JHSC, this type of discussion that Roger has outlined in his paper as well. So,
Chair, could I just very briefly just add to what Councillor Fitzsimons? I just wanted to thank Mr. Roger for your work. I think just a couple of observations, and I know that again we've mentioned about this not perhaps being directly in the the focus of our discussion deliberations, but you mention quite often in the report about a 2-site option. And I just wanted to sort of make an observation that obviously whether it's 2-site or 3-site, in some sense that there's still a risk of, you still have to look at risks and mitigation, whether you'd go for a 2 or 3-site option. But I appreciate that that's a little bit out of the discussions this evening. But for me, I just wanted to highlight page 68 very briefly, that obviously you do talk about negative impacts, and I think it's actually a really important point that you've made about highlighting certain risks. And I know that I've mentioned this before about mitigation. That's why mitigation is so important. And I think whilst they highlighted about ambulance turnarounds, I think that is something that is something that I can say personally that I'd be interested in looking at, how the IHT programme look at the risks associated with these areas. So I just wanted to thank you for highlighting those in your report. Thank you, Chair.
Thank you very much. I understand with technology that Councillor Chapman wants to come in, but he's going to try and type a question for me. He's on the phone. So, Roger, if you could just hold on a moment.
Yeah, I'm still
I don't
here.
know whether it's a direct question or it's a comment on your paper, but hopefully, let's have a look. He's not done anything yet. Hold on one second. I'm sorry, colleagues, about this. The vagaries of technology for some of us. No, nothing's come. No, thank you, Colin. I now had an answer. Bill didn't want to come in. So, Roger, thank you very much for that. I think it's a document that will stay with councillors across South West London and to make us think about the wider issues in health, as well as the local one we're talking about tonight. So thank you very much for your paper.
Thank you. Just to say that it should be the basis of further engagement. I mean, that's what the methodology promotes, and I would hope that there's proper discussion taking place at the NHS on the issues that have been raised.
Thank you very much. I can assure you that this isn't the end of the scrutiny process for any health changes in South West London. My colleagues across all the councils and Surrey will be very much talking to our health colleagues regarding things like ICSs, new CCGs, primary care networks, etc. So what you have presented to us gives us food for thought moving forward.
Thank you.
Thank you very much. If we could now move on to item 10, which I think it is Sarah and Matthew going to speak to this item.
So, Colin?
Yes, Andrew. Who's speaking to this item? Merton and Sutton Downs CCG's feedback.
Oh, okay. I thought, yes. So I know we've supplied the presentation to you.
Yep.
For the committee. Our intent was rather to take any questions that there is on the proposals, given that consultation is obviously closed, rather than walk through it, given the time I think that we have left. So it's more any questions on the presentation.
Colleagues, you've heard what Andrew said. Has anybody got comments to? I see Matthew's with us. Evening, Matthew. Or is Andrew? Are you on it, Andrew, or is Sarah on it?
No. Dr. Murray and Matthew Tate are available.
Okay.
If they would like to be taken through it. However, I think given that we've sort of come to the proposals after receiving the discussion, I think our recommendation is rather that if there's any questions on the presentation as it stands, that those are taken rather than we walk through the presentation.
Yep. Colleagues, does anybody have anything on the presentation? Are we on silence implies consent? No, Councillor Sean, you're in.
Yeah, I was just going to make the point that I think I'm not certain if there'll be much use as going through this, as it seems rather after the fact. What outcome would change as a result of any comment?
So, Councillor, if I may, so this was at the request of the committee rather than the IHG programme.
Yeah, but as I said, we've got a long time getting here, so circumstances have changed.
We would agree.
Yeah. So unless there's other comments, I would suggest, Chair, that we don't need to spend too long on this.
I suppose the idea was to use this questioning as if we wanted to as a framework to help us shape what our response might be. So if you have any questions sort of in a bit more detail to the CCGs about how the response you might want for the response.
Right. In that case, Chair, could I suppose, as this is the final part of the meeting where we are going to get My concern is the timescales that we are having to work to. We've spent a number of hours tonight going through this, and clearly we're going to have quite further informal meetings to review the evidence that we've heard today. My concern is that the timescales that were originally proposed and which we've signed up to are not really satisfactory anymore for me. And I would like to understand whether a little extra time could be given for this committee to review new paperwork so that we can be reassured that there isn't any evidence out there that we should have be considering that we haven't yet seen. And what impact would that have on the CCG if they were to put back their decision by a month or two?
Over to CCG colleagues on that one.
So, sorry, so Sarah here. I don't think,
Sarah,
can you hear me?
Yes, yes.
Yeah. So I don't think it's about the impact on the CCG per se. It's about the impact on patients, and it's on the impact on staff, and it's in the impact on services. So we have stuck to a reasonable timeline to get us to this point. We believe that this is absolutely the right thing to do for local people, and we believe that we should do it to the timescale that we have agreed, and we think that it's a reasonable timescale to stick to. So, I mean, that's our position from the NHS. We obviously are very keen that you have the opportunity to look at documentation, and this time has been built in since the start, and this has been the timeline we've been working to all along. So, and in particular in COVID, it's really important because we believe, as we said earlier, that there's actually additional benefits in COVID of this model. So it's really, really important that we make this decision, and we would like to stick to the time scale that we've put forward.
Chair, could I come back to that?
Yes, yes.
The point is, I've yet to see the evidence that this model is better under COVID-19. I have a high regard to the officers and to the medical view, but that are just. But as a long-term scrutiny member, it is worthwhile for us to be sceptical of statements without further evidence to back that up, and I have yet to be convinced by that. Secondly, this point about that, in effect, that we would be delaying improvements to healthcare. I mean, I think as someone who about 15 years ago, I sat in a meeting in Sutton, listened to Keith Exford, who was the chief executive, I think, at Sutton, at St Helier, I think, talking about the need for a new hospital. I think the public of Sutton and Merton particularly would have a view about who's been holding this up, and an extra month or two by this committee in the scheme of things is rather marginal. So again, I would ask the question, putting aside that statement that you believe it would impact on healthcare, are there any other reasons for a short delay to allow us to consider additional information?
Sarah, do you want to come in on that one?
So, Colin, I think
Matthew.
I don't know whether Matthew wants to say anything. So, Colin, I think Sarah's sort of set out the position of the CCGs, and we note what's been said, I think, around COVID, but hopefully, I think we've explained why we think it's important to continue with our decision-making timeframe. That, in summary, we will set out the outcome of the high-level strategic review of COVID. It's still an interim review that we have been working through. It will never be a full review of COVID, and the CCGs will, of course, commit to considering any further national advice, or indeed any regional advice, in due course as this emerges. But we feel now is not the time to delay the decision making. We'll set out our learning, what we think the issues are. I think We don't believe it fundamentally changes the clinical model, and we'll set out our reasoning within the decision-making business case for the governing bodies to consider, and it is for the governing bodies to consider it.
Okay, thank you. It's also, as you would appreciate, the scrutiny committees can make its comments either direct to the CCGs or to the Secretary of State. Yeah. Anita, I think you wanted to come in.
Yeah, thanks, Chair. I think it's just really an overall observation that when particularly going through the date deprivation analysis earlier and then looking at all of the impact assessments and so on so far, so gathering all the data together, I'm interested in the conclusions for further analysis. Obviously, you know, Andrew, you've mentioned about obviously the COVID and doing extra work on travel times. I noticed that there were also references to certain working groups that had done travel analysis as well, and that further work will seek to be done in certain areas to do with travel times, if that's my understanding. But I'm particularly interested in the idea of an assessment of health usage. I've got here through analysis of patient flows. And so for me, it's also about being able to get a much clearer picture of patient flows and the type of conditions that can be expected. So it's not so much to do with the amount of times people go to A&E or, you know, how old they are as per se, but it's about looking at health outcomes and looking at, you know, people's, and looking at health equality, I guess. And so I'm interested in whether that's going to be factored in into any further work that you're going to be doing. Really just to look at health usage, you know, and what types of conditions are presenting themselves in hospital. Are those sort of certain areas that you will be looking at closely as well? If you could, thanks, Chair.
So Anita, I think it's fair to say that we've already done quite a bit of work looking at the impact on both equalities groups, including those with protected characteristics, as well as those, I think, with chronic health conditions, as part of the impact analysis work, and indeed reflects, I think, on a lot of the engagement work we've done with specific groups. I think the work to date is captured as fully as possible within the integrated impact assessment, but I acknowledge the fact that the Trust will need to do further work to look at specific pathways as part of its detailed work in terms of its outline business case, which they will have to do post decision making. But our intent is not to commission any further work at this point unless the governing bodies request that as part of their deliberations. So I acknowledge they're important issues. I'm sure there's more work that could be done in the fullness of time, but I think we've had appropriate regard to those issues in our planning to date.
Okay, thank you, Andrew. I'm conscious of the time. Has anybody got any more questions?
Well, Chair, I'd just like to
Peter,
say
yes,
that
sure.
What we've been hearing is that that there are papers which are going to be considered, but they're not prepared to share them with us. The impact assessment, integrated impact assessment, has been changed, but we haven't seen it, and yet there is a determination to charge ahead with this. And to be frank, it kind of underlines the point I made at the beginning. You know, the people that I represent said that this is a done deal, that the consultation is a sham, and they are going to do this. And I think they show a contempt for those people, and they show a contempt for this committee when they are refusing to allow us to see the evidence upon which they are basing crucial decisions that affect the communities that we represent.
Thank you, Peter. Andrew, did you want to make a short comment on that, or?
No, Peter, I note your comments, and I don't agree with them, but we have heard what the committee has said, and we will make sure that we reflect back on that in the discussions we have with the governing body, and we look forward to the formal response from the committee.
Thank you, Andrew. That concludes the main part of the agenda. Item 11, I have no other urgent business come before me. Could I just thank my fellow councillors and the officers from the NHS. I must apologise for my lack of technical knowledge. I've not used Chrome before, so that created me a little problem getting in. And could I also thank any members of the public that tuned in tonight and listened to this. This is not the end of scrutiny of this particular process. We will be moving on, and we will be scrutinising whatever decision is made by the CCGs. Scrutiny from local government will continue on this matter. So thank you very much. Thank you for officers and my technical team behind on my iPad and iPhone. Thank you very much. Keep safe, everyone, and thank you very much for this evening's meeting. It's now 22:20, and thank you very much.
Thank you, Chair.
Good night. Good night.
Good night.